to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Public comment?
There was an article, I imagine some of you probably heard about it. It was either OPB or the Oregonian, and it mentioned it was basically covering rural hospitals in the state that are at risk of closure, and Lake Health District or Lake District Hospital was on the list, not for immediate risk, but it was mentioned. So I was just curious if anyone has anything to kind of say about that. I don't know if it was just kind of a fluke thing or...
This was in a press release?
This was in an article on either Oregon Public Broadcasting or the Oregonian website. I can't remember which.
So I can answer that.
Okay, I figured. In a good way.
There was a study done by a researcher. I responded to the Portland Business Journal. That I didn't know if that was what you were talking about, because that report came out and Portland Business Journal interviewed me on it.
Okay.
What this study came out with and analyzed rural hospitals throughout the United States. And there are 1,300 there are 6,000 hospitals in the United States. There are 2,600 in rural communities. Of those, I think it's roughly 1,300 are critical access. So Klamath Falls is considered a rural hospital because it's a 25,000 bed, but it's an almost 200 bed hospital. So it's not qualified, 25,000 population, but it's a almost 200 bed hospital. It is still considered small rural. So of the critical access hospitals that were analyzed, this analyst went through and looked at all of the hospitals that had, over the last 5 years, had negative margins. And there were well over 500 throughout the United States. And there were 11 within the state of Oregon that are small. Most of the ones that they targeted in that article are either district hospitals or they're part of, for example, Peace Health or Providence in a rural setting along the coast. The premise of the article is, what should the country do to deal with this issue? I can send everyone the report this analyst did. The principle that they're trying to get to is, as a country, if they were to raise the rates paid to critical access hospitals, just enough for hospitals like us to all be in the black, it would cost less than 0.5% of the entire healthcare spend in the country. Therefore, we ought to do something like this. So it's an article about, should the country do something about small hospitals all over the United States? Should it pay differently? And it looked at how you get paid. The challenge that I'm not sure they addressed well. I have read much of the article, but the 200 pages, there's a lot of data. I didn't have time to read it in the last 5 days. But what you get, and they looked at the great state of Washington and certain pockets where there are many hospitals within 30 minutes of each other, more than 30 miles, but then you look at drive time. So the requirement to be a critical access hospital, remember those 3 principal factors. Number 1, you have to be 25 beds or less. 2, you have to be more than 35 miles from the next nearest hospital. And 3, you can't have an average length of stay, average less or more than 4 patient days. There are exceptions when you have a hospital on an island that is a mile away from the next nearest hospital because you have the water to cover. Or like in Cedarville, they have a mountain pass. So there are times that it is not accessible. So those hospitals are the ones that frankly are at greater risk. Or like in the state of Iowa, where they have 99 counties, and each county has a hospital within it. Many of those hospitals are within 35 miles of each other. And is, from a health planning standpoint, do all those counties need to have a hospital, or you take out one between the two and split that up? So,
Thank
it
you.
is a complicated issue. What makes the issue about Oregon different is all of the hospitals within Oregon that are small critical access, all are at great distance from another hospital. There are 2 exceptions. Silverton Hospital is a little bit closer to Salem. And there's another Peace Health Hospital, that again, is a little bit closer to a larger hospital. But all the others, like us, as a frontier community, we are significantly distanced from the next nearest hospital is 100 miles. So that's, but this article was designed to look at health policy for the country, and what is happening in the West is very different from what happens in the eastern part of the United States. Does that answer some of your questions?
It absolutely does. Thank you.
Anything else? Okay. We have an evade training presentation. Kristen,
Excellent.
or is
She's
it
glad she
Dave?
gets to go first. I'm glad I get to go first, thank you. So good evening, my name is Kristen Hill. I'm a facility patient navigator here. I work for Teresa. I was hired in October of 2017, and I'm here to tell you a little bit about our VAVE program. And since I was here, Teresa thought it would be a great idea to provide you with a little bit of an update about what I do as far as readmissions and our work we've been doing, primarily out of our emergency department. So I was hired with money from an EOCCO, emergency department, readmission reduction grant. So EOCCO sees a lot of their members using the ER excessively, and they've asked each of the hospitals to look at ways to reduce those numbers, and that's how I was hired primarily, with the goal to reduce EMS, ED misuse, and readmission for our patients. Before I was hired here as a patient navigator, I worked in EMS, and so I certainly saw the need of that, and I saw these folks that were using the ER for their primary care, and so that really bridged nicely. When I was hired, the goal was for me to be here to help providers during the day and our nursing staff with our high need patients that just require a lot more attention and a lot more help, and someone else to call during the day. Some of the things that we've implemented and done to reduce our readmissions, we have begun and implemented collective medical, which is a computer program that basically is a database for everyone that goes to the emergency room. So we upload this database with all of our patients from the clinic, and that way we can see that Joe Smith from the clinic came to the ER on Saturday, and then they went to the Klamath ER on Sunday, and then they popped up to Portland a week later, and that just gives us a better look at our patients and what's going on. It helps us to be a little bit proactive and helps us to know where to spend our energy. We've really worked on walk-in clinic education. Now, it was kind of funny how this all fell through, but we put together some information about where to go when you have a medical problem. A lot of people don't know the different options we have: primary care versus walk-in clinic versus ER and ambulance. And so what we've done is we've developed some information to give people just information about where to go so they know what to do. This was all really kind of finished and finalized before COVID. So it got put on the back burner, and we did a little bit of press for this and we tried to really implement it. But then all of a sudden we were saying, no one come to the hospital unless it's really truly a life-threatening emergency. So it's something we've kind of thought about re-implementing and getting on our new website. In addition, we have our readmission team, and we meet weekly. And so this is just a collaborative, multidisciplinary, real-time problem-solving session for us. So we have two lists of patients. We have the folks that have been in the ER 2 times within 30 days. So we look through those and make sure that we are providing appropriate referrals, making sure their provider knows that they've been in the ER, and thinking about ways to help them. And when we meet, we have people from wellness, the clinic, the hospital, and just lots of different.
Dr. Graham's clinic.
Yep, Dr. Graham's clinic as well. So we all are able to come down, talk with physical therapy, and what referrals do we need to make to help these patients quit coming to the ER. And really the goal is for us to reduce the unnecessary emergency visits for everyone in Lake County, and especially our EOCCO cohort, that they want us to reduce those readmissions. Really the results have been pretty amazing, and I think that we've gained a lot in this. Collective Medical, which is this system we use for looking at people that go to the ER. From our readmissions, they're saying that we have 75% reduction in readmissions from the data that they are gathering. And then also with our grant, we track a specific cohort of people on EOCCO. And within the last year, when I pulled the numbers, we had 75 people that visited the ER. And from those, we were able to make 59 referrals. And out of that, 45 of those patients followed through and went and saw some sort of follow-up care. And so that was really something we were proud of. So really this helps our providers. We see that in the fatigue and burnout and the time that they spend with some of our folks that we have and on the front lines. So now I'm going to switch gears and talk about Evade a little bit. The real reason why I'm here, we received a grant through Coveries to look at workplace violence reduction. This was a grant Christy Albertson wrote about a year ago, a little over a year ago. And what came about was several years ago, our frontline staff expressed to Teresa and the team here that they were feeling unsafe and vulnerable in the emergency department. We saw a big increase in our violent patients, and they just felt like they didn't have the tools to deal with these patients. And we felt like now all of a sudden we're seeing them more often, we're seeing them more consistently. So from that, we really pushed and encouraged Charlie to hire security, which we did. We now have security on the nights and weekends here when our staff is pretty low. And along with that, we had an opportunity to apply for a $10,000 grant to change the program that we train our staff members with for how to deal with workplace violence. So we chose a program out of Idaho. It's a small mom and pop group that's grown pretty big. It's called Evade, and that acronym stands for Awareness, Vigilance, Avoidance, Defense, and Escape. And from the money we received from the grant, we were able to train myself, Heather Phillips from the ER, Heidi Martinez from Wellness, and Hector from Security to become instructors to teach all of our employees here at the hospital. So really the goal of the program is mitigating violence, and really the goal within that is to set framework for positive interactions with our patients and the people that we deal with. They talk about having a 360-degree view and awareness of what's going on. We teach how to approach people in a non-threatening manner. We talk about having your hands open and using body language to communicate with folks that's more approachable. They talk a lot about using your name when you introduce yourself. Hi, my name is Kristen. I'm here from the ER. Tell me your name. And so calling people by their name. We talk a lot about quit taking it personally. So many of our patients really make those digs at us, and really just to remember to be professional about that. We teach folks to really tap out when your buttons are pushed. When you're done with this patient and maybe it feels like it's a personal attack, who else can come in and care for this patient? How can we readjust to continue to provide compassionate care? We really encourage people to build rapport, to attentively, compassionately listen. And we really encourage people to ask questions as opposed to giving orders. Really to give people options when we talk about de-escalation. And then the goal of de-escalation is always compliance. So that's kind of the 10 foundational things that are within the class. The goal within EVADE and within this promotion of workplace violence prevention is to change the culture here. In the hospital, the culture sometimes has swayed to the point where we tolerate a lot of disruptive and rude behavior because we're so accustomed to it and we're so used to it. And so we're challenging people to really maintain a safe and healing environment and give them tools to redirect people and help them have better interactions with us. The grant had asked us to train 200 people in 2020, and we trained 201, so we just squeaked by on that. The feedback we've received from caregivers in teaching that we've done this year has been very overwhelmingly positive. I think it's a big change, and so I think it will take a while for people to get comfortable with it and really see the value in it, but I look forward to hoping to make some changes. So I appreciate your time, and while I'm here, can I answer any questions?
The security people that you have, any idea how often you've had to call them in? And the other question I have, do you have access to the police force in case you needed
We do.
to go to that?
Today we called the police to our ER and in addition asked for security during the day and had a response for a patient today. It really goes in waves. Maybe the moon cycle a little bit.
I think we use the security officers several times a week for some kind of difficult situation. What my night shift nurses tell me, and they're the ones who feel the most vulnerable, what they tell me is that since we've had security, they feel like some of that behavior has, like the word is out that we have security, and therefore they don't challenge us as much. They don't do some of the things that they were doing in terms of, I don't know, beating on the doors and trying to get in or trying to do something to the building or, you know, those different kinds of things. Some of that has subsided because the community understands that.
So just their presence then has.
Their presence has made a huge, and the nursing staff feel much, much more secure. They still talk about how grateful they are.
So are they just on duty at night?
And weekends. But we have backup during the day from both Justin and Hector, who are a part of our maintenance crew, so we can call them during business hours during the week, and then we have maintenance after hours, security after hours and on weekends. And we finally have a full complement of staff in security, so that's also helpful.
Christy, earlier, if I caught it, you mentioned that there's been a rise in outpatient violence.
I think we felt
Was
that.
that like a 20%, 50%, or did it all come at once, or what's the scenario affecting that?
I felt like it came on pretty slow, and our staff didn't do a good job documenting that. And so once we did education and talk about how the importance of documenting and writing that down, our numbers were wildly high.
Yeah, when we started tracking the events for Charlie, it was really phenomenal. I have to say that I think that unfortunately in our community there's a rise in the use of illegal drugs, and with that comes violent behavior. So that, I think those two things, that has, over the years I've been here as a nurse, I've seen that increase.
I can say that from my standpoint, I really struggled with why we as a small community would need to have security. And I felt it was much more valuable to spend more energy trying to build up our mental health services. The reality is I was wrong. We just needed more, we needed security and more mental health service. And I'm glad we have people now. It's really important to keep our staff feeling safe. And oftentimes, they would not really talk about the inappropriateness that patients or people that are in the hospital, how they behave. And I was wrong. We needed to have it, and I'm glad we have it now.
Very good. Okay, anything else?
Thanks. Thank you.
Thank you.
Thank you.
You can
I'm gonna dismiss myself. Thanks.
Thank you very much. Okay. We have next on the agenda, the approval of the consent agenda. Has everybody had a chance to read the minutes?
There's a pair of minutes.
Okay.
Was it more?
Well, Dr. Foster is not listed as.
You know, actually, after I sent those out, I realized that I had left off on the attendees. So I did correct the attendees, and there's a typo on the last page. I missed an E on more.
We don't
I
have to
will
keep coming back. so we wanna make sure
correct
it's
While Charlie is doing the financial report, I will fix the last page.
Okay, anything else? Okay,
I so believe we accept the consent agenda.
as amended.
As amended.
Second. Moved and seconded to approve the consent agenda as amended. All those in favor? Aye. Passes. Okay. Yes, indeed, the December financial report.
Well, you know, one of the things that is always the greatest pleasure is well, the first time I get to talk to you without having chief financial officer, I naturally get to have kind of crummy financial report. So thank you very much. This is really not as much fun as I hope, but it is. Pardon me?
You too?
You're up next.
So, one of the things that you need to fully understand is when we look at our volume, I think it's probably helpful to understand how much COVID has impacted us. And yes, it has impacted us a lot, and it's not so much that we have had so many patients, but the reluctance of the population to come visit our county. When you look at just, that was good, when we look at lab volume, the lab volume is down 31% year over year. Rehab is down 20%. Clinic is down 9%. Wellness is down 16%. Our surgeries, we have now significantly more surgeries. Where we had Bradbury here for a week, a month, we now have Dr. Bradbury and Dr. Chang. And our surgery volume is down 8.5%. Not because we're not delivering a good service, but because patients are reluctant to come in and be seen. And if they're not going to the clinics, what's happening is in the clinics, the doctors aren't finding those cases that need to take care of. they're showing up in the emergency room, but if that's the case, it might be that we have to ship them out because it's more than we can handle. So, it is not perfect. You can see that our radiology has been doing better, but normally that is a very strong market, as is lab and rehab. So these are indications of why we are not doing as well as we should. But that's not the only. When we look at our patient charges, December, we were just under 3.8. The average has been 3.8. So it's not all that bad in terms of our revenue. We still are below where we expected to be. Look at our collections. In December, we had quite a bit below our average of 2,260,000, and 2,154,000. We did pick up some in January, but and Susan can talk a little bit about days cash in hand. We had a good bump in November, and we didn't in December. Part of that is the holidays. Part of it is people are spending money on other things. Susan can talk a little bit more about that. You want to say anything now about that? Let's just go through this, and then you can ask questions. Hard part for me to report is for December, we had a loss of $1.2 million. Yes, we did have the biggest impact here is the revenue deductions through our contractual adjustment. A large part of that, John, you and I have spent a fair amount of that time on it, as you, John. When we took on the Cerner transition in July, we then, the revenue cycle team had to use two different systems to collect money. The old CPSI legacy system and now the new system. So they were learning the CPSI system. Sometimes they may not have been able to pay as close attention to the CPSI. But we also, as we went through the audit, finding things, there were cases where we did not collect, we were not timely. Some of those, as Susan can describe, those employees that helped us get behind where we needed to be, they don't work for us anymore. But we still, this was a cleanup time. So, not fun to be able to see. We believe that this is a part of cleaning up as we change from the CPSI system to the Cerner system. Certainly, we are well aware that this is not the kind of thing we want to see happen.
This is a cumulative lump sum that is not going to be repeated.
We believe so. There might be a little bit in January when we look at some of the other write-ups, but it's getting this. January doesn't look quite as challenging as this, in part, as Susan will say, we had some money that was held back, which impacted our collections. That came in January. So it's not, you have to look at the details to see how that balances. The rest of it, it was not that significantly different. It really is revenue deductions. And that's the biggest part. Any questions about this? Susan, would you like to add any,
Sure.
a little more detail than I have?
Absolutely. So we kind of made a strategic plan when we knew that we were going to be transitioning from CPSI into Cerner. And nothing went from CPSI into Cerner. So everything that's in Cerner is not reflective of any legacy. We targeted a 6-month time frame to try and get out of our legacy system. which we're working towards. We did collect quite a bit of money during the downtime during COVID. It was fortunate for us that we were able to use that time to really hit that legacy system hard and collect what we could collect. We did unfortunately find a great number of things between 2008 and 2019 that were not managed possibly how they should have been. Zero pay remits weren't posted, meaning we didn't have the opportunity to appeal them or correct them, and then they become timely. So there was a lot of stuff that was somewhat beyond the control of current staff. As we tried to appeal those things, anything that was as very close to timely, we've appealed to those insurance companies on those claims, saying, you know, we have this, this, and this going on. Is there any chance we can at least be partially reimbursed for these things? So write-up was the very last resort. We always face a little bit during December that of course we have people on vacation, but so do insurance companies. So they don't process as many claims as they do during other times of the year because they have people missing too. So that hits us a little bit as far as collecting on current things. So we have a few other things that are kind of barriers to our current collections in Cerner. We're really struggling in a couple of areas, and I have turned some of my attention that I was solely facing to Cerner the first 4 months, getting the staff trained and getting them comfortable with the process so that we didn't become behind on anything more. I really sat on a bucket of money that's discharge, not final bill. And when I turned my attention so much away from helping manage that, that number rose. And so I spent at least one day a week really looking at those things, getting word out to medical records, pushing out, we need to really look at these claims, these account numbers. And I really turned almost completely to CPSI so that we could get out of there before our deadline so we wouldn't extend our right-hand contract that was coming to the end of February. And so I will absolutely own that I switched, I had to do what I had to do basically. And so that I can definitely see how that has impacted our collections. We're doing the best we can. In December, we got most of the way, I would say probably halfway through 2019. So 2008 through 2019, we got basically through that. So then that brought us into the rest of 19 and 20 and the first half of 20. So we got about a year left. And most of that has been taken care of during January. So the only thing I really anticipate seeing coming back out of CPSI is a lot of the stuff that we appeal. If it's favorable, we'll get paid. If it's not favorable, we won't. So, but we were coming to the point where more and more of those things were within the timely filing period. So we pushed out a lot of claims. RICAN was not a great system. RICAN and CPSI did not communicate well. CPSI says the claim went out, RICAN never sent it, the payer never got it. So that's a lot of what we've been appealing with our explanation letters is, look, our system told us we sent it, but now we look at your system and you never received it. And so we're hoping that those things will be favorable.
For those of you that weren't here, when we had CPSI, one of the problems that we had with their portion of the software was in their business collection. And so they said, we've got a solution for it, it's called RICAN. Paid a bunch of money to get that software to work, only to find out it didn't help us. It was much more difficult than we expected, and they expected. That was unfortunate. But for Ken and John, you were not here when we did that software.
Is there any recourse against that software manufacturer?
Since they're now a legacy system, they're kind of like the Trump out of office. Can't get
I wonder if we could take a look at one of the tabs we had in the board record, which is margin by month. It's like a spreadsheet. See if I can get
the mouse. Net margin by month.
There's a tab on the
financials.
Well, there's one that says net margin.
Okay.
So I guess what concerns me is, looking back the last several years, we've never had a month like this. With that big, long line, December.
Sorry, I can't make it little, sorry, I was trying to make it larger.
What I'm saying is, this is a significant hit.
Yes, yeah. Unquestionably.
And, I guess I got involved with some Monday when I saw the finance committee meeting. And I was back on Wednesday, but it does concern me that, I hope this is a catch-up month, but I also think, and getting into this, some of this is financial mismanagement. In that when we provided services, we're not essentially getting bills out on time. And we're missing money that, because things are falling through the cracks.
You're absolutely right. You're 100% right.
So I guess what I'd like to see is I'd like you to get back to us in 2 weeks, telling us what, understanding what this was. And then also, I know one of the things that'll be nice about Cerner when we get going is it has a bunch of dashboards. And one of the dashboards, I would like to see, you figure out which dashboards they are that you can start showing us at monthly board meetings. So we know when a patient sees a doctor has the bill gone out, we aren't missing windows of timing. Because a fair amount of that money that I've got into this is because of those reasons.
There's unquestionably, you're absolutely right on. When we think about how the process occurs from when a patient is seen in the hospital, in the clinic, wherever, there is, from the day that they're seen, how quickly the doctor does their chart, how accurately they put all that information.
But there are
From
times
that
if we don't
point,
get them, we won't get paid.
there's no question about that. One of the most difficult parts that we have that delays us is when the physician, or nurse practitioner, or physician assistant sees a patient. If they don't get their charting done quickly, it delays this entire process. When it delays us, that causes our billing cycle, our revenue cycle to be delayed. And then there are other kinds of issues where we may have delivered service to someone who is not eligible. We're dealing with a big number right now on a person who was in the EOCCO, we provided service. Next thing you know, we find they're in another component of the Medicaid program. There are a lot of things that go into it. The challenge that we face as a hospital and as a community is that all of our doctors are very, very busy. There isn't one that is not. And so what we want them to do is to take care of all our patients, provide the best care that they can. If we demand that they spend all of their time on record keeping and working with the surgeon or working with before that CPSI, what ends up happening is they're not able to see as many patients. And so we have a balance that we have to try and find. This is a problem with all healthcare systems in this country.
Charlie, the other part of that is, since I've been on the board, we've probably had, 4, maybe 5 different business managers. So part of it is our own staffing job in the past, and I see these numbers now coming up, and that's
There's no
been a result
doubt
of
about
that.
it. There is not one specific place that we can say, oh, this is the only problem, or this is the only problem.
But we have to get good at, if we provide the service, that we are good at making sure that we're submitting things timely. Because other than that, we've spent all this effort to provide this quality care, which we would have gotten paid if we would have, so we have to get good at that. And so this is what happens when we're not good at it.
So This is what happens when you clean up after
Oh, I
a long
understand,
time.
this is accumulation.
One of the reasons why we changed from CPSI to CERN is financially we have much better information. One of the challenges we face is CERN is very difficult for the physicians to use. And it's time consuming. And it takes a lot of clicks. Cerner says that they're better, they count the number of clicks, because all physicians that use it complain that the number of clicks in the documentation is onerous. These are issues that, without a doubt, we have to help solve. And when we get cleanup like this, it is staggering. At the same time, you're right, we've had multiple people do it because it's a difficult job.
But what I've seen of the dashboarding, that one of the strengths of the system though, is it does provide these dashboards.
My question.
And I think what I'd like your team to get back to the board with is, these are the key dashboards or indicators of billing timing and days in, and knowing when that cutoff is. If you don't have it in by that date, we're not gonna get paid. And I think I'd like you to come back to us with, here are probably the 4 dashboards we need to be watching. And then for a while, after seeing this, I think those need to be shared with the board so we can see how we're going.
So here's what I would ask is, given the fact that we don't have a chief financial officer right now, and we may not have one for another 6 weeks, maybe 2 months, depending on how quickly we finish with interviewing. Would you give me a chance to get a chief financial officer on board? We'll see if we can get some of the dashboards quicker.
But maybe they're in place right now. I don't know.
There are many things in place, and some of it, you want to say?
Yeah, so there's a specific, it's called the Lights On Dashboard Reporting Network. So I look at that every day, and I get a historical, so on my dashboard from today, I have historical, August, September, October, November, December, January, February, right? Tells me real-time data through yesterday. So one of the reasons, I knew that we were going to have a large cleanup at CPSI. That's part of why we focused so hard on Cerner when we first had our.
So a lot of that line is stuff that was not in the new software, it was in the old
This is
software.
almost completely the old software.
That's what we've talked about, is
So-
the cleanup from the old.
The legacy.
Yeah.
Getting the dashboards, not all the dashboards have enough information in them yet. So we're working on it.
They're starting to get to that point where they are more useful to us than they were initially. So we wanted to maximize that time with the Cerner consultants that we paid for to make sure that we understood how to not get here again. And then in this cleanup process, which has been extremely tedious going through line by line on the accounts report to make sure you hit every account, we learned a lot of other things. We learned a lot of things that were happening during registration that caused refunds to have to go to payers. Because we picked 2 as primary and only 1 gets to pay as primary, and if they both pay, guess what, you get a refund. So we've learned a lot of those things during this process, so even though it is a staggering loss, we've also gained so much knowledge in moving forward that we know where we were, we know where we don't want to be again. And we've taken steps to educate the different areas of staff. Registration, I know the clinic registration staff thinks that I am just hammering them nonstop. But this is why. Because if we don't get the right information in the system and follow the process and get things done timely, John, you are absolutely right. We are doing this all for naught.
Yeah.
So,
Is there software we need to double down on? Was there not, we have enough with the financial software from them?
yeah, I think we get, yes, we get a lot, but it's very financially strong in reporting. We can drill down to exactly who has how many outstanding charts. We have lots of data that we can use. And I think getting everyone acclimated to the software was great, but we need to figure out a better way to help our doctors know what they need to do. You know when they need to have it done by.
So the other day I got a deficiency notice in my inbox, that was really helpful.
Yes, I know HIM is struggling a little bit to figure out the deficiency system,
That's
and
an HIM.
that's health information management, so medical records. So they basically get everything and then they have to parse it out. Oh, this nurse forgot to sign this, or we didn't get number of units on this, or the doctors didn't finish their discharge summary, or whatever have you be.
because they're across different sub-programs within Cerner, it's hard, I can't assign a deficiency back to acute registration because they don't use what I use, right? So we're working through the kinks of how do we communicate those things to make sure everybody knows what they need to know so that we can achieve a very smooth process. But we're all working hard together, seeing huge amounts of success between our departments in communication that we've not had in the past. And so I think everyone is beginning to understand how critical it is for us to get that information and get it in a timely fashion.
As soon as still helping with questions.
We are at the long-term support period of time now, so we have a change management line that we can call into, or we open a ticket where we have, there's a head person basically that's in charge of our account, and if we have any issues, we escalate them immediately. It's based off of financial need, patient safety, things like that, is how they rate these priority. Like I wasn't able to generate claims one day last week. It was taken care of within 4 hours. I mean, I was back to being able to do things again. So they are very responsive when the need is high.
Yeah, I know it's been a hard change going to software, we don't have a CFO, but we can't compete with this.
Okay, thank you. You're right. Okay.
Will they help us like maximize billing away?
I'll see if maybe Carly can schedule an appointment on your calendar and I can show you where we can see exactly how, there's tools for the docs where you can see how you could make your flow more efficient, where you spend too much time or not enough time to help you balance that and document faster.
Thank you.
Of course.
Okay, Mr. Quaid, you're back on.
Our balance sheet, you can see the cash change around the restricted balance. That's
Includes the Medicare reimbursement?
No, we have not received that. So one of the things that we did learn recently is that our cost report was filed. It was to have been filed by June 30. We got an extension of 60 days. We filed it at day 58. Because that's when it got completed. That's how we were able to get the audit finished. And we should be getting back an additional $2 million, roughly. That number will it'll show up about April, maybe. I think is about approximately April or May. So we're hoping that they won't treat that as money that they won't take out from the advance that we received a year ago. We received 3 sets of monies: the CARES monies, the Medicare advance dollars, and then the PPP loan dollars. We thought at one time we were going to have to return the Medicare advance dollars. We're hoping that they're not going to take the $2 million out of that Medicare advance loan. We don't know. We'll see. Any questions on the balance sheet? Next thing we need to do is talk about the budget calendar. So we're now starting with the budget cycle again. This is a very standard calendar that we prepare and provide to you starting this month. What we will do is next month we will start with providing you with some assumptions, what we think the costs going forward are going to be.
You mean this month?
In the month of March. We'll present that to you. And then we want you to approve that in March. Okay, so February 18th, we will propose the budget assumptions. We're working on, and this is to go through all the processes. The end result is that we need to have by the end of June, a board-approved budget. June 3rd is when we have our regular meeting. If we can't get a budget committee approval on the first go-around on May 19th, then we would schedule a May 27th meeting to get an approved budget. We have to have an approved budget before July. Okay, so I would ask that you have this budget calendar.
So moved that we adopt the budget calendar as presented.
I second that. Okay. Moved and seconded, any discussion? Ken? Okay, all those in favor?
Aye.
Thank you. The next item, the budgeting year for capital items has been extraordinarily difficult, especially with COVID. We budgeted, to put it into perspective, we budgeted $1.9 million in capital expenditures this fiscal year. To date, we've spent $927,000, so significantly below what we expected. And a lot of the things that we are looking at that we would spend going forward, because one of the things you've asked me is, if you spend items that have not been budgeted, don't spend something else. So we're way below what we had anticipated spending. We're not done spending money. We still have several things that we need to do that have been budgeted, and we're moving forward on those. But we will not get that $1.9 million. No chance. I sent out to you a proposal for an unbudgeted item. This is, as Dr. Than has been here, we have, and a tool that she will greatly needs is an additional ultrasound unit to be used in the office. This is the one for $42,000. Does everyone know what I'm talking about? It's a little bit more because that includes the maintenance or warranty revenue. The reason for this is the Dr. Than is examining a patient that needs to use a transducer to do the ultrasound. In radiology department, we have multiple ultrasound units. They're very, very particular about making sure those transducers don't get dropped. When they get dropped, they're very expensive to replace, multiple thousands of dollars. What we anticipate is if this is a semi-portable unit that Dr. Tan will be using in the clinic, there's a higher probability that those transducers will be dropped. So by buying the warranty, we essentially we're planning that 2 will be dropped in a year or within a 3-year time. So we do not believe this will reduce our radiology services. It's very probable that what Dr. Tan will find is she'd look at a patient and say, you know what, we need to confirm that you're this or something like that. So, but it is a very helpful tool as she and the other doctors are caring for patients. I would recommend that we buy this non-budgeted $42,000 piece of equipment.
So all the doctors would have access to it.
They would. It is predominantly used for patients that are either dealing with pregnancy issues or other gynecological issues.
Any discussion?
I have a small thing that I use in my clinic. I use it on all the OB patients. But sometimes, I don't find sometimes it doesn't work right. And I'll send them to an ultrasound. So the answer is small. On occasion, I mean, I would be sending to the ultrasound unit here in the radiology department when I see something. it for Parkinson's.
What it really does is it's a tool for the doctors to say, you know what, I need to have somebody else read this. Radiology. Get a different view of it. So that's why this is a very valuable tool. That's my motion.
I would so move that we would authorize the purchase of the ultrasound equipment and warranty as presented.
And the total on that dollar amount was?
It's $42,000 for the piece of equipment and about just shy of $4,000 for the warranty and it's predominantly for the transfers. The actual piece of equipment doesn't get trouble.
Well, I amend the motion that had these numbers in.
The capital item is only the $42,000.
Yeah.
The other item is a service, what's considered a service agreement. But I didn't want it to appear that we weren't clear on.
Clear? Okay. Motion's been made, and I hear a second. Second, that we go ahead with the purchase of the ultrasound as presented. All those in favor?
Aye.
Okay, Goose Lake Medical Services.
Goose Lake continues to struggle with the same issue that we have and had for a long time. We can't admit people. In fact, we actually had a case this past month where a patient that had been sent to the St. Charles Bend. The Bend Hospital was full. They called the state to demand that we be opened to allow that patient to come back. And the state capitulated and allowed us to accept the patient. So it isn't that we wouldn't want to get them, but because of the risk of COVID, whenever someone, either a patient or an employee tests positive, or the number of patients that are positive in the community goes up, that requires that we test patients in long-term care in the system twice a week, plus all employees that actually go into the building.
Have the residents of these locations.
They have all that want, right, they don't require something that doesn't want. But yes, and they've all gotten their, virtually all have gotten their first shot or their second shot is on the way. So it's within a couple days. So we are doing all that we can to protect them. Of course, everyone wears proper PPE. I mean, this is our most vulnerable portion of the population. So we're doing all we can. But as a consequence, our census, which drives all this, has been tough on us. You can look at all the factors that lead to that, and we continue to have it's not unexpected, it's undesirable results. Not at all what we want, but we continue to struggle with contract labor. Let's talk a little bit about that. It's just very, very difficult. You can't get more patients into the facility. I like to believe that this is going to change in the near future, especially as we're vaccinating more. Any questions?
Recruitment update. Rebecca, how are you doing?
I'm good. Thank you guys for allowing me to speak tonight. I've got a couple of things to update you on. First, as Charlie mentioned, we're interviewing CFO candidates. We had 2 telephone interviews initially, and then we had a group interview through Zoom. with all the teams that would report to the new CFO. And we're bringing them out for a site visit. It'll be, I just got the dates from one of them today, the other one's supposed to get back to me by tomorrow, but sometime over the next 2 weeks is what I'm trying to book for, so. I will let you know.
What sort of support can you ask from the board? What can we do to help?
Well, Charlie? He was asking what kind of support the board can offer in the CFO search.
Oh, in the CFO search?
Uh-huh.
Nothing. We're doing fine. This is not our first time applying, interviewing people. If the board members would like to be involved in some of the interviewing, we're certainly happy to accommodate that. We certainly make that. Is that something that the board would like to be participating in?
Well, we're looking for ways to help.
In terms of ways to help, I think we want to think about, what I brought up here is, when we think about how many people we look for, these are the current job postings that we have for positions that we're looking for. So when you look at that, so for example, in this page here, EVS is environmental services, which is housekeeping. If the board could help with us finding people that would be willing to provide that service, we would ask for all help possible. Our part is how we find people. Our Lakeview Gardens, we're constantly looking for nurses, for CNAs, as you can see, the contract labor issue.
We're gonna talk about the scholarship program at all tonight.
Yes.
We are going to, yes. But we wanted to talk a little bit about recruitment. Our needs are staggering. And you'd think with an unemployment rate, we would have no problem finding people, right? One of the hardest problems that we face, all the people that want to go into, that we would like to go into long-term care, number one, they have to be willing. Number two, they have to pass a drug test. And number three, they have to pass a criminal background check. It is not uncommon that some of those don't get passed in the candidates that we want. Those are requirements that we have to have that other employers don't have. So sometimes it's difficult to find people that can meet those criteria and want to work.
Rebecca, approximately how many job openings do we have?
There's about 26, 27 openings, and that's more position openings. And some of them, like EVS, might require, we could use 4 more people for EVS right now, 4 more full-time. So, going to the NA program, the first thing I want to do is
What program?
the nursing assistant program that would feed into the CNA certification and then into working primarily long-term care and then acute. So the first thing I want to do is apologize. I was so concentrated on trying to find candidates that I did not invite you to the interviews. So I apologize for that. Completely didn't even realize I needed to, so I'm so sorry. But there it was, right there in black and white after that was brought to my attention. So I apologize that you weren't in on those interviews. So we started advertising the next day after we got confirmation from the instructor for KCC, Marilyn Cole. And so we started advertising in December. We advertised throughout the entire month of January. We ran radio ads. Of course, it was on all of the internet job boards that we normally post on, with the biggest one where we get a lot of our candidates from being Indeed and the state job boards, both for Oregon and California. And then we also had Dan Decker, I mentioned the radio program. Dan Decker did a great radio commercial. I don't know if you've heard it or not, but we ran that on average 2 times an hour for the entire month of January. And we did get a total of 7 out of a possible 10 applicants that we could have had. Out of the 7 applicants, as Charlie mentioned, you have the difficulty of finding candidates that can pass a drug test and pass the criminal background check. And the criminal background check is pretty stringent because, of course, this is our vulnerable population that they're dealing with. So right off the bat, we had 2 that weren't able to fulfill the requirements of the application process. And then we ended up with 5 that we made offers to. Out of the 5 that we made offers to on the first day, we lost a couple. One had a family emergency and will try and come back if they can in another class in the future. And at that time, we'll of course have to go through the whole process, the application process with the drug test and the background check and so on. The other person had a different kind of family emergency and they're not returning to Lakeview. So we ended up with 3. With the 3, we feel pretty confident that 3 will be able to get through the program. There's no promises or guarantees. One did have to miss 1 day of class because we had to retest that person for COVID because of an exposure. So they missed that class. They're allowed to miss 1 class and that's it during the whole program. So the program runs February 1st, and it was going to go to the 1st of April, but because we have a reduced class size, that allows for more concentrated and accelerated teaching. So they'll finish on March the 24th. So a whole almost 2 weeks sooner than originally planned. And then they will matriculate right to long-term care, and then they will sit for their exams, and we will anxiously wait to hear how it goes. Michelle Williams, who is our assistant DNS, is helping out, as well as Marilyn Culp, who's doing the instruction. So she's going to help out with, Michelle's going to help out with tutoring during that time. So we feel pretty pleased with who is in the class as far as their willingness to work with people.
Is it all classroom instruction or
No.
are they working down here in the
So
classroom?
it's a combination. So they start out in a classroom and they're working online. And then they work with the instructor then in clinicals in a couple of weeks. So, yeah. And we did make, I made a connection with the Oregon State Employment Agency, and I'm talking to them about the possibility of a grant that we might be able to get for future classes that would pay for this. So we're just in the early stages of talking and seeing what they're able to do. They run like an internship program. You can get that. And it would be about the same amount we're paying KCC now.
Great.
So do you have any questions about that at all?
I assume when this one finishes, we'll start another one.
We're hoping so. We've got these in the wings that weren't able to come to this class. So we've got 2 in the wings. One I didn't even mention because the day that she turned in her application, she realized that she wouldn't be able to start until maybe summer. We were in the summer program.
Very positive.
And then may I take a minute and answer your question, Ken? Ken asked earlier how many people out at Christmas Valley that Judy had done, and it's 100. She says that she's done out there.
And that's administered through the Pine or Public Health.
No, it's our
It's
public.
our public health.
I think we did it. Christmas Valley.
Oh, yeah.
Okay.
I can
it's-
provide you
yeah, it's
that information.
Just curious, how
We
how
did.
many and
I'll
Public Health?
address that my remarks.
Thank you.
Thanks, Rebecca.
Thank you. Okay, medical staff privileging. Foster, you're on.
Just one renewal here. Terms are dietitian.
Just needs renewal.
Just needs renewal.
Just renewal.
Renewal, yeah, I know Karen, very nice ladies.
That's all.
They have a recommendation for medical staff privileging for Tara Dial and dietary, right?
Yes.
Motion to accept. Oh, I so moved that.
Okay, good. Everybody.
To accept, that's, what do you call it?
It's the medical staff recommendation.
Medical staff recommendation for Tara.
Second.
Okay, got moved and seconded to approve the medical staff privileging as presented. All those in favor?
Aye.
Okay, thank you, Dr. Foster. Teresa, you're up.
Okay, just a couple little things, I guess. Well, we've certainly been busy, so I'm thinking you'll see a better financial report next month, but we've had an explosion of what they're calling COVID babies, so we have had a lot of more babies per month than we've had in a long time. OB is very busy, and we've been busy on the floor. We've certainly had times when we had no patients in the hospital that had COVID, and we've had other times when we do have patients in the hospital with COVID, so that kind of ebbs and flows. We've had, for some reason, a little bit of an uptick in staff who've undergone COVID, or are positive for COVID and out on leave. Our staff are usually out for 10 days at least if they test positive. So that's a bit of a struggle at times, just with staffing. It's also been a bit of a struggle because we've tried to be really generous with our public and allow visitors in because we think that's really important for our patients. There are hospitals that don't allow any visitors that haven't since the start of COVID. One of the downsides with that is that sometimes we have people come in who may have been exposed themselves, the visitors, and then that puts our patients at risk. So we're kind of struggling with that. We're probably going to do a little bit of a campaign to try to get our visitors to be much more compliant with masking, just to protect our patients and our staff, because it has such a huge effect on us. So that's a bit of you might hear some feedback on that in the future. And other than that, we're still working and hoping. We think we've hired a sleep lab tech, but he's had some issues that delayed him in coming. So we're hoping for him to be here by March, and then we're also looking for a cardiopulmonary manager. So there's, between babies and medical leaves, the cardiopulmonary department has been a little bit thin, but hopefully that will change fairly soon. So that's kind of my report.
Do you think it'll help with your staffing, that the nurses have had their shots, the vaccine, and that should help with staffing?
Well, just like the rest of Lake County, not all nurses chose to get their shots. So I think Mesa said today we're just a bit over 50% with our employees that chose to be vaccinated. So, and that's pretty much the national average. Some places are having a higher amount. So I think it will help, John. I think anything helps, because then there's the ones that have had COVID and the ones that got vaccinated. I'm hoping for a little bit of an effect by that, but Dr. Foster can probably say better than I don't know what percent it takes to get herd immunity, but I think it's a little higher than where we're at now, so
And herd immunity at least 70%.
70, so,
I've thought a lot about this, and my idea, ultimately, we just find those people who haven't had COVID, and vaccinate those people, and whatever that number is, and get that number up to 70%. It would be good. Bro, nationally, we're only like 2%, but 70% is the magic number.
Are we getting all the vaccine we want, or are we waiting all the?
It's a good question. We
No.
vaccinated a bunch of people yesterday.
we did, we knew that vaccine was coming, we already had a waiting list from, this is what Judy from Public Health tells us. So they were able to vaccinate that group, but now we have no more known vaccine coming. The state has indicated that we will be getting it, but we,
You don't know how much or when.
no, and there's been quite a bit, Charlie probably can address this better than I can. You know, there's a real push in the metropolitan areas to kind of decrease the amount that's going to rural communities, as I understand it. Is that correct, Charlie?
That is correct. So, just to put it in perspective, we have vaccinated we have done over 800 vaccinations. Of that, in Lake County. Of that, 120 have been vaccinated in North, over 120. Of those people that have been vaccinated, there's been about 130 have had their second dose, roughly. So remember, they have to have their first shot, then 28 days later, they have to have the second shot to be completely vaccinated. In order to get herd immunity that Dr. Foster talked about, we need to vaccinate 5,600 people in Lake County. 70%. Is that going to happen? Right now, what's happening in the state is the state is getting about 100,000 vaccines a week. No, a month. No, it is a week. Sorry. And about 20,000 are going to the CVS to vaccinate long-term care facilities. The other 80,000 is getting spread around the state. We are getting vaccines to EMS, public health, to our employee health. 3 centers. And we've got it in the 100-dose containers with 10 vials. Each one has 10 doses, roughly. Sometimes it's 11, sometimes it's just 10, so it's hard to say exactly. As you know, the governor changed her rules from it first being 1As, all healthcare providers, and at-risk people that are first responders. Then it was to allow teachers. Then it was maybe not teachers, maybe it should be seniors. Now what the concern is, so we got a lot of vaccines for first responders. We didn't have 600 frontline healthcare workers and first responders, so we started giving it to others. The urban settings, that's not happening at all, especially in the Portland metropolis or city. Now, it looks like from a political standpoint, the state will be holding back for rural settings and spending much more time focusing on vaccinating urban settings. Because in urban settings, they haven't even vaccinated all of the 1As, healthcare providers, and first responders. Although teachers are getting their vaccination too. So,
How is this going to affect the second dosage?
so we are assured that we will get adequate vaccines to give all that got their first dose the second dose. What we don't know is how much more will we, it's the same medicine, so it's not like they look different. What we don't know is will we get more to do the first doses? And time will tell. And this is an item that changes not quite every day, but close. Okay. Teresa, sorry, is that?
I was done, that was all I had unless you had any other questions for me.
Questions?
Thank you, Teresa.
Thank you, Teresa. Very good. Okay, CEO report, Charlie.
So I talked a little bit about our vaccination process. Our numbers, as Teresa said, we do have had some current recent outbreaks. We are now up to not what it says behind me, we're at 298. We also have 41 active. What that means is we're currently at the low risk. We probably will change. What we don't know is whether we go to moderate or high risk. Because some of the people may or may not be deemed by the state as impacting whether or not the county has changed from its designation. Of the vaccinations, if you go to the website and look to see how many people have been vaccinated, one of the things that does happen is if people leave the county and go get vaccinated someplace else. They may be residents here, we get counted. That vaccination, if they got it in Climate or in Deschutes County, it gets counted. So that's why the numbers aren't always exactly what we administer. Okay? Not exactly an exciting thing, but we are managing that. A lot of the small hospitals like us, when it comes to caring for their patients, they have not kept their COVID patients. They have shipped them out to other hospitals. We've been able to manage many of our patients here. And that's a tribute to the quality of the nursing staff and our physicians managing those patients. Sometimes we've managed to the best of our ability, and they still have to get sent out. So there's a variety of different kinds of levels of care. But not all hospitals have been doing that. Any questions about what's happening with the front of face always COVID issues?
They change tomorrow.
I beg your pardon?
They will change tomorrow.
That'll probably change later this evening. It is virtually impossible to stay current. So no matter what I say today, it'll be different tomorrow.
Along that line with the screening in front, we're closing at 5 now. But we consider people still have appointments after 5. So that's creating some communication. So we thought about
We have. Every time we extend the hours, what that does is it requires greeters to be present longer. It requires a lot of people to be present longer. When we talk about staffing, one of the things we talk about often is what happens about weekends. We now have laboratory people here, both Saturday and Sunday. We provide rehab services on the weekend. So somebody is coming to the hospital from the therapy department or rehab department, both Saturday and Sunday. We have so much business happening on the weekends that we're almost to a point of having radiology tech full-time on the weekend. They're called in almost that much. The problem is we're 2 people short. So now we've got to find more therapists. And so every time we add those services, it isn't just one department. It impacts all sorts of areas. But we are considering that. Please keep in mind, when we talk about having this many services available, do we want to open up a walk-in clinic on Saturday? If we do that, Howard's has said they would potentially be open on Saturday. That would be huge for it. The question is, can we get all the other components, not just one, to make that happen? So it's not a simple answer, though. We schedule our laboratory people to be here until 6, because people that are seen at 5, if they can't get into the office, run down to the emergency room. We still have to run lab and x-ray studies often, not always, but so are we staggering our employees to be late? So it isn't just simply, can we just open the doors and they go? Still got to control access. Other questions? When we talk about recruitment, I think it's important to understand we have such a difficult time finding people. We're not alone. I think I may have told some of you, one of the many calls I was on, the head of OHSU nursing said, we can't find CNAs in Portland. There are times that hospitals can't accept more patients because they don't have CNAs or nurses. So this is an ongoing problem. One of the ways that a lot of hospitals, a lot of organizations are trying to find replacements is they're using agencies, or what we call headhunters. But every time you do that, remember they charge 10, 15 to 20%, 25% of the salary of that person. So when we think about that, it's an expensive endeavor. And even when we hire and pay those fees, they have a hard time finding. We have what's called ghosting. They actually have come up with a term for it. And that's where you have somebody, you've interviewed them, they were ready to come to work, they say everything sounds good, their agency firm has said, oh yeah, they're all ready to go. And then they don't return calls. And you've never heard from them again. They've ghosted us, gone someplace else. That happens frequently. And we think, how can you possibly do that? We had an agreement. And they don't. Our next strategy is to try bundling groups of jobs and saying, tell you what, agent headhunting firm, we'll give you all these for a fee. Can you do that? It's difficult. And we don't have a set answer. If you have any knowledge of people that might be looking for our suggestions, we are 100% willing to hear and take them on what we can do to try and find them. We've talked about maybe going to other parts of the country and doing job fairs. Well, going there is great, except COVID is here. Now you can't travel there, and you can't bring them in to interview. We've talked about several of the smaller hospitals have said, why don't we form our own recruiting agency? Because we're all in trouble trying to figure this out. And several have said, I'd be willing to put up money to do it. Of course, you gotta find a recruiter.
We also do the virtual job fairs currently, but a lot of people don't show up for those either.
And when they do, what they really say is, yes, I'm interested in Oregon. I'm interested in the coast of Portland. If you're not one of those, actually, I don't really care about the coast. I just want to go to Portland. Salem has that problem. People go to Salem and say, I'll take the job there until I have enough experience or until I get a job in Portland. That's the draw of Portland. So that's not a whine, that's just the reality. The building that we bought, where we're going to move the business office to, we just signed a contract to have heating and air conditioning built in. I thought we'd be in, we thought we could have it done right away. hopefully they'll have the heating and air conditioning done toward the end of this month. Some of that's a function of J. Brown's. The contractor that we expected to be able to do the project, that we had talked to about doing it, didn't ghost us. But said I got too much business, I'm not gonna come out. So sometimes my expectations, because I told you I thought by February 1st, one of the problems that we have when we expect our revenue cycle team to do their optimum, it does not help if we keep moving. It does not help if they work from home and we can't stay on top of it. So we're not exactly, we're asking them to do a lot of work and we've got one hand tied behind your back. That's not really fair.
We do need
You know what?
Hey, you know what, we said we'd take a space heater and a blanket.
Because one of the last things we need to do is start getting into a building and then have trouble. So you have to make the creature comforts done.
I'll go and fix a kerosene heater for you.
Perfect. We'll just
I don't
open the
wanna set
window
the
for
place on-
ventilation.
They can, but I don't wanna set the place on fire. And so we wanna be very sensitive about that. So I apologize, we're behind, and not only that, it costs more than our anticipated budget. So we think we will still be able to stay within our budget, but that specific component we underestimated. When it comes to you may recall I asked the board to approve the purchase of a Lucas 3 device. And this is the device that could be used by the EMS team if a person is in a cardiac arrest to provide the CPR. We actually got to use it within this last month. And the patient was brought to the emergency room, left the community for care, and the patient returned. Now, did we say that we saved that person's life? I don't know. But it was a fabulous thing to be able to use that service. And I think you should know that while we hope we never have to use it, we got to use it. And that may have meant the difference of that person's survival. So it was a wonderful thing. Thank you for approving. Last thing I have is that we continue in our saga of negotiating with the Teamsters. If you recall, the Teamsters union contract was up December 31st. They are still in discussions. As soon as I have final, I can bring that for you. I think I sent to you a letter from some of the employers in our businesses in the community, asking that if we were to, once again, in past years we have given employees a gift certificate to spend some money around Christmas time in local businesses. We have not made that available to all businesses. And I was reminded of that by some of the smaller businesses, to make sure that we, should we do that in the future, we make that available. So we will do all that we can to do. If you hadn't heard about it, well, tell me. So I know many of the employees took advantage of that. We made the gift certificate this year a little bit bigger than we have in the past because we were not able to have a holiday Christmas party because many of the employees find that to be very much appreciated, and while they may not have said that to you directly, they have said that to me. Some have used it to have it go toward some of the local nonprofit entities. So that is, let me give that as an option too. Those conclude my remarks. Does anyone have questions about any of the issues that we are struggling with or looking?
just need a little clarification. Earlier in the budget, you mentioned that our visitation is down because of COVID, people not wanting to come here. Yes, but we are increasing some of our services on the weekends. And how do those two match?
So part of the reason why people are not showing is they're afraid of coming here. One of the things that we do find is that people come to our emergency room seeking care, or they've been in the hospital and we need to like inpatient. So our radiology, our lab, and our rehab, much of that is inpatient care. It isn't just outpatient. We're not doing a lot of outpatient services on the weekends. They're either emergency room or inpatient care. Okay. Now, if we can get to where post-COVID patients are no longer afraid of coming, remember, a lot of people are still very, very fearful. A lot of people don't leave their house, or very limited where they, others are not concerned about this at all. But a lot of people have been anxious about it. We hope, and it's not just here, it's across the country. There are many, many organizations that are experiencing the exact same thing when it comes to lower census. Others are being absolutely inundated. Other questions?
I would just like to talk a little about, perhaps tonight or at least at a coming meeting, to talk about the nursing scholarship program.
We can talk about that.
Not just the CNA, but the whole program from starting as a CNA or all the way through being an RN. And what we can do to help recruit local people to get that certification and training and support them.
So, John, one of the things I meant to talk about that, I apologize for you asking that. We do have a very defined process on how we handle grant requests. We set that up through the Patricia Gaining Fund process. And this is maybe new as new board members. Those members that have been on the board longer are aware of the process. We have an application process that is available in HR. People have applied, and then HR, or Human Resources Department, will vet the requests and provide requests for their books, their tuition is going to be, any other costs. We then bring that application to the board, where the board makes the final determination. We talked about how that Patricia Gaining Fund was all but depleted. It wasn't completely depleted because when we make these grades, we have a requirement that if the person that applies doesn't stay here for, they're not indentured service, but if they don't stay for 3 years, they have to pay back a portion of their money. And so we've had many people that have received the money, gone to the class, gotten their degrees, gotten their certifications, and have stayed here for a year and left if they have to pay a portion of that. So we continue to have portions of that money coming back. But we did deplete the preponderance of that money. We then, last spring, received a grant from Providence Health System of $50,000. And we have an anonymous donor that matched that. We now have approximately $100,000 in fund to pay for students. And we have not defined it as exclusively nursing. So other people have used that money and they apply and we have that available. We have tried to have the money be in the ballpark of $3,500 per student per year. That has been our target when we had Patricia Gaining One thing that changed the amount of money that we had was the availability of KCC nursing. So very quickly, we had a lot of people apply, we used that money. Many of those people that were students became employees and are working here or have been. What's interesting is just today, I got a letter from both announcing the program that the St. Charles Health System Scholarship Fund, coupling with the junior college in the Bend area, that they will provide $1,000 per student per year as a grant for the same kind of thing that we're paying significantly more. So we do have a process. We have not pushed it a lot, in part because with KCC being limited, so in preparation for that, we've tried to focus on more of the advanced portions of the nursing school. We haven't paid for the prerequisites that some people might want to do first. The second part about that is we've used a lot of that money to pay for CNA training. And the same thing is happening with the St. Charles Foundation and their school for the CNA training. They're giving them $1,000. We continue to provide scholarship, and of course we are paying KCC for 10 students to go through the program.
Well, I just look at, I think we've had the most success in recruiting nurses or people that have ties to Lakeland. So like you said, they, when you get to Portland and the coast, if we can take people who have ties to this community, they'll probably stay there too. And I mean, I think we should think outside the box there where maybe we provide daycare when they go to school. What else can we do? Maybe we have to pay for prerequisites to get people that have ties to our community to get the certifications and education so they can be a productive member in the hospital and have a good career. So how do we do that? And I think you look at the amount of money we're spending on traveling nurses, it's there. We just spend it in different ways. So I guess I'd like to see you guys come back to us with some different ways we could get Lakeview people to get into nursing careers here.
So one of the things that we often, our organizations like ours often do is create a foundation to generate enough money to be able to give away that money. When organizations like a hospital set up a foundation, a lot of the ways that you feed that foundation is through wills and when people expire and family wants to support the community. Some time ago, it was recommended that before we set up a foundation, a lot of people in our community have used the estate planning to support our very, very valuable school programs through the daily fund and the other things we've done. One of the things that we want to balance as an organization is, do we want to take opportunities that are being used in people's estate planning to build up for something here versus supporting the daily fund that comments made on. There's a limit.
But I think individual families have to make that decision. I think
You're absolutely right. But when we start asking families to compete foundation to foundation, make that choice, then it has been recommended. Now that's something you may want to consider changing, but that's been the suggested plan for quite some time. And that is such a valuable community resource.
The daily fund, Collins McDonald, go to all the guys graduating, all the guys Sounds graduating.
Question?
I think the point here is he's trying to make is how do we keep them here? Because our kids are graduating and moving on elsewhere, they're not staying to be an RN or a CNA here. And that's the difficulty, how do we recruit and keep people in town?
My question is, maybe for Teresa, a lot of the kids, like our motto is, we expert cows and kids. But how much of those kids that does move off, is there just a street talk about how many, what percentage of those desire to be RN?
I guess I don't know the percent. I know sort of roughly out of our high school, probably 1 to 2 a year go to a nursing program. And then there's those that go later. There's even those that have a different career and then go back to nursing even later. But I mean, what I see is 1 or 2 a year. And we have that program that we work with the high school where they come in, the health careers class, and so they come through and then some of those are more active and come and work as a CNA for us. I mean, I have 2 that have been coming back now for 2-3 years. No, actually I have 3 that have been coming back for 2 to 3 years. They come back on their holidays and their summers and they work as a CNA and then they go back and they, they're either going through their prereqs or then they get into nursing school and they still come back. I have one who's waiting to try to get into medical school. So we have that kind of business going on regularly. I guess I answered your question.
Mostly interested, how much interest of all the kids going through, what's the interest in being?
Well, I think, I don't know where we're at with making that program understood by the students in the high school. And I don't know what we're saying about prereqs. I've heard from the people that I talked to that they would appreciate some help with prerequisites because before you can get into nursing school, you have to get through a lot of classes and you have to go. So, I mean, most of these are people that are working. Oftentimes they work here as in some type of a job or in the clinic. And so, whatever, I think it's definitely worth our while. I don't know if we formulated that program well enough that we can be telling our high school students what's available. I hope we get there.
Charlie, you think that's something maybe you guys can come back to us in a few years more, maybe with maybe some recommendations and changes to or enhancements to the gaming programs that we could maybe help recruit more people?
Yes, we'd be happy to do that.
The schools have a career day, once a year?
Yes,
And we participate in that,
yes,
maybe just expand on that.
yes. And I've reached out to the school district several times and talked to them. And of course, are they open, are they closed, what's gonna happen? So,
This has been a difficult year,
very difficult.
but our hope is that we'll be able to expand on what the school has done. Many of you know Bobby Stininger. She has a stalwart supporter of the medical field and has really worked hard to introduce lots and lots of people to the opportunities in whether it's a hospital or any kind of medical service. And she's quite good at that. And at one point in time, she says, I've done enough of this. We have opportunities to expand on that. You're right, there might be a greater opportunity. She's been a very strong supporter of our community in that good. That concludes my comments. If you don't have any other questions.
Okay, we have, one item, okay? We'll, adjourn and, go into executive session after 5 minutes.